We now come to the last talk of the day, Dr. Nirupama. She is going to give us the take-home pearls and wrap up the session. Dr. Nirupama is an additional professor in JIPMER. She was the head of the department of ophthalmology there and a very brilliant ophthalmologist. Over to you.
A very good morning. As we come to an end of this instruction course, so I would sum it all up and give a few take-home pearls. So to optimize the IOL power calculation and reach the target refraction, we have to keep three things in mind. One is to make the biometry measurements as accurate as possible using the latest tools and technologies. Second is to use the advanced generation formulae to calculate the IOL power. And third is to give due considerations to all the special situations like we discussed today, whether it's a toric IOL, post-refractive surgery eyes, post-vitreoretinal surgery eyes, or if it is extremes of axial length like long or short eyes. So the first and foremost, before doing the biometry, please check whether the ocular surface is good, rule out any dry eye status. If the patient is wearing any contact lens, it should be discontinued even before doing a keratometry. Measure the keratometry on a virgin cornea even before application of any eye drops or contact procedures. So always repeat the biometry on the same day with two different instruments or on two different or three different instances to make sure that the calculation is bang on the target. And we can also repeat with one or more formulae and interpret the values with caution. Always look at the raw data and check whether there is any asymmetry between the two eyes. So check for all these red flags when there are any variation from the normal range and then recheck the measurements. So always consider what the patient wants, whether he wants emetropia for distance, intermediate or near, and depending on that we need to choose the type of IOL, and always counsel the patient also depending on what will be achieved. And look at your own results, and you can actually adjust the A constant, and that will shift the power prediction curve and optimize the IOL formula to work well across all ranges of IOL. So for toric IOLs, always use toric IOL when it's a stable, consistent and regular astigmatism, and avoid toric IOL when it is any irregular astigmatism. Always check the cylinder in the spectacle refraction, the optical biometer and topography, and see whether you are getting similar readings, and use the Barrett toric calculator. So that comes with both predicted and measured posterior corneal astigmatism, and both actually are giving very good accurate results. And this posterior corneal astigmatism definitely has to be taken into account when calculating the IOL power for toric IOLs. Otherwise with the rule astigmatism we'll end up with overcorrection, and for against the rule astigmatism we'll end up with undercorrection. And always when we calculate the IOL power, the toricity which is on the cornea is different from the toricity which is in the IOL plane, and usually the toricity on the IOL plane is around 1.5 times greater than the corneal toricity. Always consider the age of the patient, because young patients usually have with the rule astigmatism and older patients have against the rule astigmatism. And if we are using consistent temporal clear corneal incisions, usually the surgically induced astigmatism is very minimal and close to zero, and it is the centroid value which is around 0.08 to 0.14. And always do a proper surgical technique and OVD washout at the end of the surgery. And if there is an error or there is a rotation of the toric IOL, we have the astigmatismfix.com or Barrett RX formula, which will help us to know how much to re-rotate the IOL. So looking at the advanced tools and techniques that are available for us, we have different biometers which are giving very accurate measurements, of which the swept source OCT based machines like the Zeiss IOL Master 700, the Argos by Alcon, the Tomy and Antirion by Heidelberg Engineering, they are the best and they are more popular, which are used nowadays. The advanced formulae, especially those which are hybrid which use both virgins and the artificial intelligence incorporated, are giving excellent results. And the best part is we have online calculators which are available free, especially in the ASCRS or APACRS websites, which are accessible to everyone and can be used. And we also have the aberrometers, the pre-op wavefront aberrometers and intraoperative aberrometers, which actually help us to fine-tune and achieve more precision. And even in the IOL armamentarium, we have very good IOLs, and even for higher powers, we have customized power IOLs which are available. So these all actually help us to achieve a very good post-op refractive outcome. So in VR surgery eyes, Dr. Arup has covered. So silicone oil eye fields always tend to overestimate the axial length, and eyes with a macular edema or if there is a bullous retinal detachment where the retina is slightly forward, that tends to underestimate the axial length, especially if you are using a ultrasound biometer. So always opt for optical biometer, and for silicone oil filled eyes we can also use a correction factor or schedule the surgery after silicone oil removal, or as Dr. Arup has mentioned, always do the biometry even before doing the silicone oil installation in the eye. And for gas filled eyes, there could be a forward shift of the iris lens diaphragm, so we can actually aim for a target hyperopic refraction. And scleral buckling surgery, it tends to cause globe lengthening, and that can result in a myopic surprise. So these situations actually tend to give refractive surprises to us. For post-refractive surgery eyes, if it is post-radial keratotomy, there is both alteration in anterior and posterior curvature, whereas if it is post-laser vision correction procedures, there is only alteration in the anterior curvature and the optic zone. So the formula where the effective lens position is calculated using the corneal curvature actually tends to give erroneous results. And since we have the Barrett True K Universal 2 formula, which actually is the most accurate in post refractive surgery eyes. Same thing applies even for irregular corneas like keratoconus or post LASIK ectasia. And the use of true keratometry or the total keratometry using the swept source OC devices, where the anterior curvature, posterior curvature and the central corneal thickness together gives us the accurate K reading should be used. And we can also use the Scheimpflug devices as it was discussed, where the holiday EKR report we get a K reading. These give good outcomes in post refractive surgery eyes. And for extremes of eyes, if it is a long eye, always there is an error because of posterior staphyloma, and there is actually a paraxial overestimation leading to a hyperopic refractive surprise. So for the older formulae, we use the Bangkok modification, but now Barrett Universal 2 is giving the best results for long eyes. And short eyes, actually the estimation of effective lens position is the one which is erroneous, and small errors also are magnified because of the higher powered IOL. And we can use higher powered IOLs like we saw, even up to 40 diopter is available, but piggyback IOLs also are good options in short eyes because the spherical aberration seems to be less. With this, we end the instruction course. Thank you. Over to Dr. Aru.
Thanks a lot, Dr.